Welcome to NDCPD's Collaboration for Change webinar series. While we're waiting, please add your city and state in the chat so we can see where everyone is from. As well, tell us your role and what agency you work for. All right, again, welcome to NDCPD's Collaboration for Change webinar series. My name is Vanessa Rovig, and I'll be your facilitator for today. This is our last webinar in this series. If you've been attending the past webinars, we hope you've enjoyed the content out of all the presentations.
All right, Vanessa, do I go ahead and share?
We just have a couple slides here, Olivia. Yep, and then I'll introduce you. You bet. For those of you who are familiar with NDCPD, great. For those who aren't, we're a University Center of Excellence on Developmental Disabilities, also known as a UCED, and we're part of a national network of 67 other UCEDs throughout the U.S. We serve the North Dakota disability community by providing training, technical assistance, services, and information. We have approximately 15 to 20 projects at NDCPD that cover a range of topics connected to disabilities: employment, housing, education, and early intervention, just to name a few. We're also excited to announce that this is NDCPD's 35th anniversary. More to come on that throughout the year. You can check us out at www.ndcpd.org. Today is the fifth and last webinar. It's been a great 5 weeks. NDCPD is hosting today's event as an informal exchange on specific disability topics. With this event, we hope to build a community of individuals and agencies with a common interest in disabilities. A couple housekeeping notes. We will be recording today's event, and the recordings will eventually be available on our website. We'll have time at the end of today's session for Q&A from our presenter. To get your feedback on today's session, we will have a short online survey. The link for this survey will be in the chat at the end of today's session and also emailed to you after today's session. We will appreciate any feedback. Up to 5 contact hours will be available for social work or nursing, depending on how many sessions you attend. If you want contact hours, you must complete this online survey. As well, contact hours will only be granted to those who attend the live sessions. Watching the recordings after the fact will not count towards contact hours. This is different from last year. And with that, I believe we're ready to get things started. Today's webinar is titled Neurodevelopmental Disabilities, the Importance of Early Intervention and the Basics of Behavior Interventions. Today's presenter is Olivia Holter from the University of Utah, and now we will turn the attention over to our guest speaker. Welcome, Olivia.
Hi, everyone. Just 1 second. I'm going to go ahead and share my screen here. Okay. So yes, my name is Dr. Olivia Holter. I am a assistant professor at the University of Utah's College of Health Sciences. Specifically, I'm in the Department of General Pediatrics, and I am in a clinic called the University of Utah's Developmental Assessment Clinics. In my role, I am very much an academician. So I'm an academic, but I also still work as a clinician. And with that in mind, I was letting our hosts know beforehand. We had a bunch of snow in Salt Lake overnight, as I think you guys are having some crazy weather up there in North Dakota. I was at one of our clinics this morning, and I didn't want a chance being late for this. So I'm joining you guys today from one of our clinics. I'm joining from our integrated behavioral health clinic at the West High School. So it's a school-based clinic. So just so you guys know, if there's any bells in the background, that is why. But just a little bit of information about me. Again, my name is Olivia Holter. I'm a licensed psychologist. I graduated from the University of Montana. I was born and raised in Montana. I grew up in Helena and I lived in Missoula for about a decade before leaving for my it's very similar to a residency. We call it a predoctoral internship. I have, as a practitioner, worked in a number of different settings. So I'm also a dually credentialed, so I'm a school psychologist. I've worked in about 23 different schools and districts across several different states. So Montana, Illinois, and Washington. In Montana in particular, I had a lot of experience in working with rural schools and including one-room schoolhouses. I'm sure there's some still in North Dakota as well as there was in Montana. I'm very much, I do a lot of work in integrated primary care. So I'm here at one of our integrated school-based primary care clinics today, but that was where my residency was. And I do a lot of outpatient behavioral health, and I work in now. My primary location is a multidisciplinary specialized clinic specializing in neurodevelopmental disabilities. As a scientist, I do a lot of research and looking at just barriers to accessing education and health for a number of different groups of individuals. And so I won't spend any more time here. And I kind of today, my presentation is big, and I feel like both parts of this could be its own presentation, if not its own class. So what we're going to do today is we're just going to do a brief overview of both of these topics, knowing that there's a lot more to dive into. And one of the things that I did for you guys with my PDF, there's a lot more information embedded in the PDF of my PowerPoint, so you can click on a lot of the links and get access to a number of different resources that I hope will be helpful for you in your work. I was just reading through the chat as we started, and it was amazing to see what you all do. And I wish we had time for me to ask you all a bunch of questions. But just an overview, when you're talking about this idea of neurodevelopmental disorders, neurodevelopmental disabilities or disorders are a group of disabilities where condition is set early in the developmental period. And so typically it's within that birth to 3 range. And there can be a range of just different deficits that arise with these neurodevelopmental disabilities, including just difficulties of executive functioning, global impairments, social skills issues, issues with cognition or intelligence, just other things, medical conditions as well, motor skills, lots of different things kind of fit under this large umbrella. Speech and language, I didn't hit that one, fit under this umbrella of neurodevelopmental disabilities. With that in mind, neurodevelopmental disorders, neurodevelopmental disabilities often frequently co-occur. So someone with ADHD and autism, there's a high comorbidity between the two of those conditions. And so when you're talking, and this is just a little bit again of when you're talking about neurodevelopmental disorders, screening and identification of those early in the developmental period is really important. And this is just kind of an overview of how, especially in the primary care setting, we can start with identifying a number of these neurodevelopmental disorders. And it really starts, again, at home in that primary care, that pediatrics office. So there should be a number of screenings that happen throughout that that early developmental period, that newborn care, that health and those supervision visits, and hopefully early on we can catch a lot of those, especially more medical pieces. Early identification, and this is just another slide on this, again, as I said, really starts in that primary care and in the home setting. And primary care physicians in particular should be screening for and know of things like a history of prematurity, low birth weight, or other kind of neonatal complications, things like fetal alcohol exposures, fetal drug impacts, those types of things. And in that primary care setting too, hopefully people will be doing surveillance of those developmental milestones. And if you have a kid yourself, you've probably filled out one of these checklists where you're kind of going down and asking yourself, can my kid string beads on a string? But those screenings are really important, and they do help us catch where when kids are behind. Other places, though, and other things, those regular health screenings as well, hearing screenings, those types of things. But other places this can come up to is just concerns raised by preschool educators. I know I saw at least one of you out there. It works in Head Start. And I think this is a really common thing that I hear in my role as someone who does assessments for autism, for ADHD, is I hear from people, oh, my kid's preschool teacher brought up these things, and these are the concerns. And this got me questioning whether autism fits for my kid. And I did some research, and now we're on this path to seeing if autism makes sense. I also think, not discounting parents' judgment themselves. I know a lot of you out there, I saw parent empowerment specialists, parent coaches, people that work for parents. And I'll talk a little bit about this here later. But I think hearing out parents and hearing out their concerns is one of the most important things any healthcare provider can do. I hear this so much. So I specialize in working and identifying neurodevelopmental disabilities in older kids. And when I say older kids, that's in quotations because we're saying kids 4 to 17. So I do a lot of autism and ADHD evaluations in those age ranges. And especially for my kids that are 7, 8, 9, something I hear really frequently from parents is I've always known that something was not quite right. I brought it up to my pediatrician, but they were always, borderline in terms of their developmental milestones. There wasn't something that was just quite wrong enough for us to have the alarm bells ring and then to move on to a next step for an evaluation. So I think, hearing out parents' concern, and sometimes two parents will talk about having their concerns dismissed. They're saying, no, your kid's fine. Just let them, they're a late bloomer. They're a boy. They're X, Y, and Z. And so I think, hearing out those parent concerns is really important as well. Concerns raised by other professionals is also important. I know it sounds like a lot of you out there are social workers, maybe working with adults too in therapeutic settings. And I know I've worked as a rural clinician, I've worked with people across the lifespan providing therapeutic services. I've worked with parents before, and in my therapy office, I've even heard from parents, gosh, this has been happening with my son, and these are the things I'm concerned, but I feel like no one's hearing me out. What do I do? And I think, even if you don't specifically work with children, even if you don't specifically work in early childhood, if you work with people who are parents, knowing about developmental milestones and sharing your concerns, I think is a really important thing. I know one family I worked with, one adult that I worked with years ago, brought up some concerns that they were having with one of their kids and parenting one of their kids. And we talked about it. I ended up recommending an autism evaluation. And from that recommendation, that kiddo ended up getting diagnosed or evaluated and diagnosed with autism. So even if you're not directly working with those kids, I think hearing out parents and then making sure that you can empower them to make decisions and send them to where they can actually get some more support can be really life-changing as well. Again, we don't have a ton of time today, but I wanted to share this with you all. I did make sure that this was an updated link address, but the CDC has a 1-hour training. And it's actually, if you're a Head Start or early childhood educator, you can actually get CE credits for this training. But it's just a 1-hour training, and it goes over monitoring and documenting developmental milestones for kids. And if you also don't work with young kids often, this is a really helpful link where you can just go and learn more about it. With that in mind too, I think this idea of how to act. So no matter what your role is, I think open, honest communication is really important. So sharing the positive, even if you're working with parents, right? Oh my gosh, it sounds like you're working so hard. You're doing so much for your child. However, it sounds like you're still struggling. Have you heard or seen this? Have you heard of ADHD? Have you heard of autism? Is there any way that I can help you get to the support you need? And I think just making sure to communicate in a very straightforward and constructive way can be really helpful. And I think too, if you're an early childhood educator, I actually took this slide from a presentation I did earlier this year for early childhood educators as well. But just talking with them early, sharing the positive, and also then that allows you to kind of share the negative as well. And I'm saying to early childhood education, this is actually an example from my own child's preschool. And so what's something that my kids' preschool does is they actually document developmental milestones that they see, and they send it to me in an app. And I think, again, sharing the positive also allows and opens the door to saying, hey, like we haven't seen, so my son's name is Asher. We haven't seen Asher doing these things that are normal for a 2-year-old. Can you, have you seen this too? Is this consistent? Have you considered talking to his pediatrician? Have you considered doing something, talking to early intervention? And just because I am very much in the world of autism and ADHD, I wanted to provide just a brief overview. And I know that a lot of you have experience with this. So I won't spend a lot of time here, but I did want to just mention, so both ADHD and autism are under that umbrella of neurodevelopmental disabilities, neurodevelopmental disorders. ADHD, I think, is best characterized as a neurodevelopmental disorder where the primary deficit is in what we consider executive functioning. If you've never heard of that term, executive functioning, it's the frontal lobe of your brain. It's everything that the frontal lobe of your brain controls. And when you're talking about, in particular, kids, we're talking about comparing kids to other same age kids. I think a lot of ADHD symptoms, especially for boys and sometimes for young girls, can just be swept under the rug of, oh, it's just boys being boys, or that girl just has their head in the clouds, those types of things. But in comparison to other kids, they're struggling with executive functioning. They're more inattentive, or they're more hyperactive, they're more impulsive, or that combined presentation as well. And again, really, the symptoms for this are typically onset before age 12. Typically, you're not looking at a diagnosis of ADHD until age 5. However, there are some cases where kids have more extreme ADHD presentations, and you can consider that in a younger kiddo as well. But so ADHD there's a lot of really excellent data out there. ADHD can be really well evaluated and identified in the primary care setting. So not necessarily something where a kid needs to go and get an extensive evaluation, but primary care physicians can definitely be a really great first stop in making sure, if you have concerns for ADHD, of kind of screening for that. That being said, I will say sometimes the way that pediatricians do screen for ADHD, it's looking a lot more at those externalizing symptoms. So for some kids with more of that inattentive presentation, also sometimes for girls, those screeners can also come up with a false negative, say we're not seeing a clinically significant level of ADHD symptoms, when perhaps that child actually does meet criteria. They just are not demonstrating those symptoms in a way that adults, teachers, people can see. They're not the kid that's getting up out of their seat, walking to the window, or pushing their friends. So if that's the case, then going on to a psychological evaluation or a social worker with expertise in the evaluation and diagnosis of ADHD could be a really great next step for a kiddo, or a psychiatrist. I know, that being said, those are very few and far between. Autism, I could go on and on about autism for a very long time. But when you're talking about autism and just kind of understanding and screening for autism, what people should know is just autism itself, I think, is best conceptualized as a neurodevelopmental disability where people are struggling with learning from others. When people talk about autism, we often talk about the overt behaviors that are really easy to see. Things like hand flapping, not making eye contact, things like the rigidity, the struggling with transition, maybe even sometimes kids that are not able to speak early on. But kind of more subtle signs too can be things like not learning social rules easily. So having parents need to explain social rules 5 or 6 times. Needing to hear again and again, when you're having a conversation with someone, make sure to look at that person. When you are having a back and forth conversation, you can't just talk about the things that you want to talk about. You have to ask them, how was your day? And have that true reciprocity. And if you haven't heard of that kind of conceptualization of autism, of a disability of learning from others, there's a really good book. It's called Life is with Others, and it's by a psychiatrist whose name is Donald Cohen. And it really talks a lot about this idea with autism. And this is especially when you're talking about kids or people with what has historically been considered high functioning. I don't like that term. I think it's very ableist in terms of a term, and I don't have a ton of time to go into that. But with autism, if you're a person that requires less support, a lot of times what I hear from people is they've spent their entire life teaching themselves how to they don't inherently get the social rules. Where most neurotypical kids, they can watch other people and they can say, okay, I need to take turns on the slide. I need to take turns on the swing. Kids with autism might have to sit back and teach themselves how to do those things. And it takes a lot of mental energy and a mental effort to do those things. I once had a teenager who used this really wonderful analogy. And bear with me, I love analogies. I'm an acceptance and commitment therapist as well. But he used this analogy where he talked about neurotypical people function almost like old RPV tube TVs. And if you don't know how an old RPV tube TV functions, they take in all sorts of information from the world. They take in even garbage information, and then they're able to display a picture and with audio connected to it. Whereas a person with autism, he explained, he almost works in a way where his brain is like works with binary. And what that means is that if 1 or 0 is out of place, like with instructions, if there's something that's not quite right, things don't compute. Right. And I think that's a really beautiful analogy, because if you think about it, with an RPV tube TV, the capabilities of display of audio and visual capabilities are not that high. But if you think about code, while there might be upfront some limitations where if 1 or 0 is out of place, if it's not that black and white, it doesn't compute. But the kind of the capabilities of that are limitless. And I think that's a really wonderful analogy, especially with ability. I think being aware of the signs and symptoms of especially both ADHD and autism is really important. Being able to communicate your concerns to parents in whatever capacity you're working with those parents. I see a lot of nurses on here as well. If you're seeing signs and symptoms too, talking to that patient's provider saying, hey, have you noticed these things? Should we have a conversation with parents? Have we thought about these ideas? That could be helpful as well, and making sure that parents are getting to the help and the support that they need. With that in mind, early identification, especially of autism, autism can be diagnosed very early. So you can diagnose autism reliably at 18 months of age for children. And especially when you're talking about autism at that young, autism doesn't necessarily need a comprehensive psychological evaluation. It can be diagnosed, identified by pediatricians with special developmental training. So developmental pediatricians or even just general pediatricians with special training can do that diagnosis. Psychologists also are kind of the historic go-to in terms of psychological evaluations. And especially sometimes I think even in that early age range, if kids are more complex, they still might need to go to someone with more training in evaluation. But I think the most important thing is getting kids, catching, diagnosing, identifying early, and then getting them to the services that they need. Early identification too, in terms of when you're talking about, again, that broad umbrella of neurodevelopmental disabilities, developmental delays, anything like that, catching those things early in the pediatrics office or in the early childhood, early preschool Head Start areas can be really important. But then also connecting families to programs like early intervention. Sometimes birth to 3 is the term people use. If you've never heard of early intervention, it's a term just kind of used to describe federally funded And oftentimes there's a lot of state funding that goes into it, services and supports that are available to babies and young children with developmental delays and disabilities. It can include things like speech therapy, physical therapy, behavioral therapies, other services based on the needs of the family and the child. And at this time, early intervention, those birth to three services, if a child meets criteria for those birth to three services, it's a free service. It's not billed because it's under that umbrella of special education. It's not typically something that families have a copay or a cost associated with it. If you're not familiar with birth to three services, then and early intervention, I put on here everybody's in North Dakota's, at least your early intervention centers. And I put on there just a hyperlink to this webpage too. If you're from out of state, I saw some people from different areas as well. I highly recommend, again, even if you are not working in early intervention, bookmark where those services are for your county, for your area. And that way you have it as something that you can provide to families when and if you need it. Anyone can request an evaluation for those early intervention services. I think, other resources too. Sometimes I hear things like, I have gone through the early intervention evaluation. My kid was on the borderline. They said that they couldn't get those services. I need some services for my kid. We live in a rural community. There's no other services available. If families are struggling to get services, there are helps. There is help available. I would love to hear some time about what everyone that's doing parent coaching is doing. Because I think, connecting people with these wonderful parent coaches, these parent advocates. One of my favorite organizations is just Family Voices, and Family Voices is a national organization, and they're typically state-run. There are typically state-run kind of branches of Family Voices that are run by parents of kids with disabilities for parents of kids with disabilities. And I've also kind of put in here the hyperlink for the Family Voices of North Dakota. So why should we identify and address concerns early? When you're identifying early concern, or when you're identifying and addressing concerns early, connecting kids to the right resources, to the right therapies, you're going to see large increases for both parents in social and emotional development. You're going to have parents feeling like they're more capable of parenting their child. So I didn't actually put this in here, but research on early intervention, early access to different therapies. And I'm using early intervention here as kind of an umbrella term of early therapies under 5. I'm not specifically meaning early intervention, birth to 3 services. But when you get kids early intervention, you also see increases in parent efficacy, feeling as if they're able to do better as a parent. You're going to see increase in those everyday self-help skills, or what we call adaptive skills. Increases in areas of deficit as well. So whatever that child is coming in, whether it's motor skills, their speech language skills, cognitive skills, behavioral skills. And I really think, especially when you're talking about kids before the age of 5, intervening is really important, because development is a moving target, right? If you have a kid that is behind, even if they're still progressing, but slowly, their peers might be progressing more at a quicker pace. And so the gap is just going to get bigger, even if they're just progressing slowly. So making sure that we get kids to the correct intervention so we can kind of help catch them up as much as we can to peers is really important. And I'm realizing the way that I'm sharing this does not have my wonderful animations, but I think a lot of you who are parent coaches, work with parent organizations, already know this. But when you're a parent of a child with a developmental disability, that really means taking on an active role as an advocate. And I'm saying developmental disability, but even just children with developmental delays. And frankly, even just the way that our current medical and educational system is set up, I think being a parent means being an advocate for your child and helping them access what they need. Our systems are not user-friendly. And those who are able to advocate, unfortunately, tend to get better and earlier services more often. There's a lot of research on this area in particular. When even kids, so when parents, even if they know something is wrong, if they're not able to effectively communicate to their pediatrician, to their teachers, to the people in their life, they might not get the services that they need. And right now, kids that are lower SES, and also children of color, typically receive later in life identification of neurodevelopmental disabilities. And it might not be because parents don't notice something early on. Typically, they are noticing something early on. But often, what's happening again is that they don't feel like they're able to advocate in those settings. I highlighted a recent study, and I say recent, and it's because 2020 feels like yesterday. Um, but there is this Atkins and colleagues study. And really, the findings of the study, the finding that I found the most compelling of this study. So, when you're talking about early intervention referrals, and the path to early intervention referrals can come from a number of different ways. A lot of times, I would say a large bulk of those early intervention referrals are likely coming from general pediatricians' offices and saying, hey, why don't you go and get evaluated by early intervention for services. Um, Only 62% of those initial referrals resulted in an evaluation. So, of all of the children that were referred, only 62% of them then came into the office or were contacted and successfully set up an early intervention referral. Of those referrals, a large portion of those kids were actually eligible for early intervention services. So, around 69%, 70% of kids from those who were referred were eligible for services. And then 34% of those kids that were eligible for services actually then enrolled in early intervention and got those services. So you have kind of this funnel of kids where we have a large amount of kids, only 62% of them were actually evaluated, a smaller amount were eligible for services, and then a very small amount of those kids were actually enrolled in those services. And then again, the finding I found most compelling in this study was of the kids who were not evaluated, about 70% of them were likely to have qualified based off of the data that was found in the study. And the most of them that didn't come in for their initial evaluation were never contacted by early intervention services to set up that initial evaluation. And I think this happens a lot in healthcare where a provider will say, I sent in a referral. And they likely did send in that referral. But the other side of that is, as a parent or as even just a person just in the healthcare system, the second part of that is you likely should be calling that referral partner and asking yourself to set up an appointment. And so again, this kind of highlights the importance of being a parent, being an advocate as a parent, right? So if your pediatrician says, hey, have you considered early intervention? There's that initial referral, but then making sure you yourself are calling and getting those services. I think, again, I always give a little bit of a pep talk whenever I give a first-time diagnosis of any neurodevelopmental disability. But I really think, again, when you have a kiddo with a neurodevelopmental disability, learning to take on that role of advocate is such an important piece of helping your kid get to the services that they need. And then, especially for later on in life, learning how to help that child as a parent become that advocate for themselves. I mean, I think everyone in this Zoom meeting can probably think of a time where you yourself, even as a healthcare professional, or even as someone who works within these systems, had to advocate for yourself to get something that you needed. And a lot of people don't know how to do that. So I think that's a really important skill. So this is just my quick run through early intervention. I hope that, again, the big thing is just early identification, early intervention is really important. Connecting kids to the right therapy services early is what's going to help set them up for success later on in life. Development is a moving target, and we want to make sure that we can identify and get kids to the services early. And then the other side of that is even no matter what your role is, even if you work with adults, I think knowing developmental milestones, knowing how to talk to people about, hey, I've noticed these things. Is there any way I can support you, can also be really helpful. All right. Um, so talking a little bit more, let's go ahead and shift our focus to behavior. And I'm just going to go ahead and let's just, oops. Sorry, the way I'm sharing this right now, having to make this work while I'm here at the clinic is a little bit funky, but I work a lot with this therapy. It's called the modular approach to therapy for children. And if you've never heard of it and you work with kids and families, I would highly recommend looking into it. It's just a really wonderful therapy. They also offer, so they have a training in a module called parent management training. And so this right here, this kind of theory is adapted from this match ADTC for kids. And I like it in terms of understanding, why do kids behave the way that they do? Why do kids do what they do? And I think if you are a therapist, or if you work in early childhood education or work with kids with behavioral problems, you've likely heard this from parents or from teachers. They come in and you're like, oh my gosh, like, I'm just gonna use my son's name because it's easy. Asher is doing this again, and I just like don't understand why. And the reason why can be really complicated. So coming in, obviously those child factors, the biological factors can include those neurodevelopmental disabilities, prenatal exposures, a number of different biological predispositions, things like personality and temperament. We don't have a ton of time to get into them today, but there's a lot of research, especially on early childhood temperament. And if you have a more challenging infant or toddler, parents often really struggle with them, and it can really impact behavior and then the relationship between parent and child. And those their early childhood experiences as well. So things, I do want to touch on those briefly. Um, but those kind of go into life events as well. But your experiences also can include things just like reinforcement from parents. Parent factors, things, obviously parents themselves come in with their own biological factors, right? So do parents themselves have neurodevelopmental disabilities? It's not uncommon for me to have parents who might have unidentified autism or ADHD themselves. And it's, if you're talking about autism is at its core a difficulty in learning from others and being able to understand those social nuances, it's really hard when you're a neurotypical person sometimes to identify challenges in your own children. But imagine having autism and having a difficulty with those things already, and then trying to being told later in life that, hey, your kiddo is having trouble with social skills. They're struggling with conversations, and they might not even see that. Parents come in with their own personality, their own temperaments, their own mental health concerns, and we don't have a ton of time to touch on this either. But parental mental health is also a really important factor in parent-child relationship, and especially early infant bonding. Life events as well. So positive life events, negative life events, where a child is raised, their socioeconomic status, all of those different things, as well as the consequences that happen and shape behaviors over time. So things like reinforcement, punishment, escape, attention, and we can talk about those. We'll talk about those a little bit more in depth today. But just wanted to touch on, if you've never seen the structural and social determinants of health and development, I would really highly recommend looking this up and doing a little bit more reading. But in terms of life events, just at its core, those I think it's important to understand that children and families exist within a broader context. And so we have these interpersonal, institutional, community, public policy interactions that are happening and can really impact a child's behavior. I think one really important example right now in a lot of the work that I'm doing is kids that come here undocumented. And it was not their choice. And now we are having all these different ICE raids, and it's making them feel really unsafe and impacting their behavior. I think a lot of people, especially if you've been in social work for a while or working with kids for a while, might have heard this term. It's called ACEs, the adverse childhood experiences. But children who impact or have experienced any of these ACEs, so things like abuse, household challenges, housing insecurity. I saw someone at least out there was a housing specialist, and Not having a home is really impactful. I think too, if you're not familiar, now I'm on an aside, if you're not familiar with home or what's considered homelessness, for children, especially under this McKinney-Vento Act. Being unhoused also includes living living with friends or family members. So living in short-term housing, things like hotels, things like also impermanent structures. So sometimes even mobile trailers can count under that McKinney-Vento and housing insecurity. So I think just if you're not familiar with McKinney-Vento and just what kind of actually constitutes homelessness, I would highly recommend looking at that. But all of those, the housing instability can absolutely and does impact children. Things like just, parent stress, trauma, neglect, all of those things impact here or are under here. And also, so thinking too, just a little bit about things like family substance use problems, parent mental health problems, all of these can absolutely impact behavior. Family factors as well, so things like parenting style. So if you've never heard of the types of parenting style, there's 4 basic types of parenting. So there's this authoritarian parents who are domineering, kind of very it's like a dictatorship in that home. There's permissive parents who are overly lenient. There are very few demands. They almost kind of treat their children like friends. There's also uninvolved, neglectful parents. And then finally, kind of what is considered like the gold standard is that authoritative parenting. And that kind of brings us to talking a little bit more about what parenting, the role is. Authoritative parenting, as I said, is kind of often considered the ideal parenting style because of its balance of warmth and responsiveness with clear expectations and firm boundaries. This approach really fosters a healthy parent-child relationship. I like to think about authoritative parenting as kind of like bowling with bumpers, right? So you're still getting to the end, but parents are there and they're gonna kind of help get the kid there. Another kind of a good example of what authoritative parenting can look like is where an authoritarian parent might say you have to be home by, like if you have a teenager, they have a curfew, they need to be home by 9 p.m. Where a authoritative parenting style might be, hey, I want you to text me when you're leaving your friend's house, and I want you to leave by 8:45 p.m., but then drive and get home safely. And if you think about it, if you tell a kid to get home by 9 p.m., what if if there's trains, if there's snow, if there's delays, and then if they're still going to get in trouble if they like stopped for a train or they drove safely or they helped a little grandma cross the street, but they're still going to get in trouble by if they get home at like 9:05, that would be very much that authoritarian parent, where an authoritative parent saying leave by 8:45 p.m., tell me you're on your way, and then make sure that you get there. That's kind of again bowling with bumpers, allowing a little bit of wiggle room for the unexpected to happen. Parents play a very large role in behavior, and I think it's really important to understand that too. If you've never heard of the coercive parent-child cycle, it's really important to understand. Parenting is the hardest job in the world, and I really know and understand that. And sometimes it is easier for parents just to do something that they ask a parent or their child to do. But oftentimes, if that happens enough over time, parents are just reinforcing negative behaviors, whining, some of the things that they often want therapists to help them get rid of later on. And so I did put some of this information in here. I do think it's important to understand too, kids with neurodevelopmental disabilities are hard to parent. ADHD in particular. So there is a developmental pathway and comorbidity where kids with ADHD are, especially the hyperactive impulsive type, are harder to parent. They are more likely to develop oppositional defiant disorder. Kids with ODD are more likely then to develop conduct disorder, and then conduct disorder is a developmental precursor to antisocial personality disorder and just more antisocial traits. And I'm not saying that every kid with ADHD is going to go on to develop conduct disorder or antisocial traits. However, this is a developmental pathway, especially when you're talking about other external factors, coercive parenting cycles being present. If there is not intervention, this could be something that kids can develop. And so I think that really does play into the importance of intervening. Um, just basics in terms of behavioral intervention. If you've never heard of a functional behavior analysis, this is definitely an entire degree. We've got our registered behavior technicians out there who have their entire master's just in understanding behavior and this right here. But the basics of it is when you're talking about when something happens, understanding why did it happen, this can help kind of break down why did it happen. So thinking about what was happening before, specifically what the behavior was, and then specifically what the consequence was following the behavior. A great example of this, I was once in a classroom and a kid was being really oppositional and the teacher wanted me to come and just observe the classroom. And so they were doing a math lesson. Everyone was raising their hand to answer questions. The teacher didn't answer or call on this kid. And so the kid crumpled up his paper and threw it across the room. Immediately, when the kid did that, the teacher then came and talked to him and gave him attention. And so, kind of knowing exactly right there what was happening. If you don't know the basics between punishment and reinforcement, punishment really is going to be meant to decrease a behavior, where reinforcement increases a behavior. And I have a couple of examples here. Unfortunately, again, it's just a quick tour today. But I really also think making sure that parents are matching, like, are you trying to increase the behavior or decrease the behavior? And then being effective in, if you aren't using punishment, making sure that it's applied immediately, effectively, and not in a way where there's like coercion or emotions involved. And so consequences are really important. As I mentioned, I think one of the most important things to understand too is attention is one of the most, especially in early childhood, is one of the most reinforcing things that you can provide. And oftentimes, especially young kids, and especially if they're experiencing neglect or not getting the attention they need at home, they are not going to differentiate between positive attention and negative attention. And so helping them understand that, I think, is helping parents even understand, or teachers, like, yelling at this kid, he wants your attention. He doesn't care if you're yelling at him. That's what he wants, can be really helpful. I put in here some other the most evidence-based strategies in terms of punishment include things like timeout, the power, again, I put in here too. Active ignoring or selective ignoring is another thing that can be really helpful. So if a kid is whining, just not paying attention to it and then reinforcing when they are following directions can be really helpful. So there's active ignoring here. I also think prevention is a really important strategy for kids, increasing non-contingent positive attention, things like one-on-one time. Even so, for teachers, there's a really excellent just one-on-one time intervention of like trying to spend 5 minutes a day with a kid that is a problem kid, and just giving them that non-contingent attention. I've had families who come in for parent management training and they stop coming after the one-on-one time because the behaviors just totally go away. I think also providing effective instructions is a great prevention strategy for problem behaviors. I put in here some really wonderful kind of examples, and it's hard to change the way that you give instructions. So I know even as a parent, I do things like this, and it's just like, let's clean up your room. I'm not going to help pick up your toys. Like, you know how to put them in the basket. Let's go ahead and do this together. Or you're going to go ahead and do this. So changing the way that you do that. Increasing positive behaviors, rewards. Rewards don't have to cost anything. One common thing that I do hear often with rewards is people are worried about spoiling kids, or that they're like making it so that they're only going to behave because of rewards. And that doesn't happen. Research tells us that it's actually the opposite, that rewards typically help us at the beginning, but over time, kids need them less and less. And then we're almost out of time, but I did want to just note one thing. One thing I sometimes hear from parents is that they want to reduce things like stimming behaviors in public for their kids with autism, things like hand flapping, jumping. And really, I think in terms of just our, I think it's it's important to kind of see that as just like ableism within our communities. And it's okay for kids to stim. And I think helping parents understand how to kind of, instead of, like, hey, let's not stop Asher from hand flapping in public. Let's go ahead and just help you understand how to communicate to other people. He's a kid with autism. He expresses his emotions differently. This is how he's going to express his emotions. And I love this too. For stimming behaviors, only intervene if they're causing significant disruption to daily life, impacting learning or social interactions, or have the um, or are have the potential to harm themselves or others. I put in here some great evidence-based interventions, and we'll go ahead and wrap up. I'm just going to go ahead and stop sharing. There's lots of citations, but let's go ahead and do some questions.
Wonderful. Thank you so much, Olivia, for that. Christine and I are going to just go through the chat here. But if anyone wants to put their hand up, if they have questions that they'd like to ask specifically, we can definitely do that as well.
One thing I see in here too from Amanda is my kid's pediatrician has never suggested early intervention. She has made referrals to other agencies or other essential health departments to be evaluated, but never mentioned EI. I think that's definitely some people's experiences. And I think this is a way to maybe something that you can educate your pediatrician about, like, hey, have you heard about this? This is a free service. It's something that you can refer to if your kids are not in that age range anymore, just letting them know, hey, for other people, this would have been, so saying this would have been really helpful for me to know as a parent. I want you to know about it so you can provide that resource to other people.
And there was a question regarding the PowerPoint, and we'll have it on the website later today. It is okay to share, right, Olivia?
Oh yeah, please.
Okay.
I see in here too. So Kristen said, I think there's still quite a lot of stigma and misinformation that impacts parents' experiences of whether to take or seek services for their children. I see adults and believe that when when people saw things early, they didn't intervene for a variety of reasons. I think that's also really important. I love that point, Kristen. I hear this a lot because I hear from parents, especially for kids that require less support. They're wondering why and identify or why a diagnosis or why identifying might help them out. And I think this is where a lot of the more invisible impacts are present. So things like anxiety, things like depression. So early intervention and providing children with the proper therapies and especially neuroaffirming therapies can help prevent anxiety, can help prevent depression, can help prevent substance abuse later on in life. I love that point.
Looks like there's another question here, Olivia. Do you have any recommendations for approaching parents with authoritative parenting style and how that may contribute to a child's behaviors?
In terms of yeah. That's a hard one. I think in terms of it kind of depends on your role with the kid. I think so and I think too, just being really aware of the cultural pieces too. So I know there are some cultures where they're just more naturally authoritative in their parenting style. At that point too, like as if you're a mental health therapist or you're a someone working with that child, something you could potentially help that kid do is learn how to navigate those cultural expectations and parents' authoritative parenting style. So I know in particular in the past I've worked with a couple of older adolescents with especially so their parents were from South Korea and their parents had a very authoritative parenting style, and so kind of helping understand where their parents were coming from, where these expectations are coming from, and then navigating also what that looks like in the world. In terms of actually talking to the parents, I think helping them understand how, again, using examples. Okay, so when you set such a hard boundary of you need to get A's in every single class, you are helping kind of you're saying that this child has to be perfect. And this, I feel like this might be impacting them in terms of their developing perfectionism or their I think that this might be help or struggling with this. Is there any way we can shift the expectation of just putting your best foot forward? And helping them kind of understand maybe the impact of what those really black and white expectations do to their child. It's hard, and I think you can come into it with a lot of empathy. One of the things I often tell parents is right now in our world there is information overload on parenting. There you cannot go on any website without kind of seeing someone share their 2 cents about what it means to be a good parent. And there are, manuals, there are books on how to parent, but most of us learn how to parent from being parented, from what we saw as parents. And right now, I think, approaching parenting almost like a scientist, asking yourself, is what we're doing working? And if it's not working and the evidence shows you that it's not working, it's time to change something else. Frankly, too, some people will have very black and white beliefs. I did parent management training once, and at this point too, it's really hard as a therapist if you have one parent that really wants to change things and one parent that's not willing to change anything. Sometimes there's nothing you can do, and what you're saying at that point is just, hey, look, I've given you the tools. If you're not willing to try them, you're going to continue to see the same results. You're going to continue to see these same negative behaviors, and helping parents understand that. Ooh, how do you approach kids that are parents that don't want their child to have a diagnosis? I think that's a hard one too. And it really depends on the situation. So I have a family member who so has a kiddo that very likely has autism, and they've talked to me on and off for years about the pros and cons of seeking a diagnosis. And I think there are a lot of opinions, especially about what like the benefits of getting a diagnosis versus the negatives. And a lot of people are really worried that their child is going to kind of get lost in this idea of like, I have autism, and so this is who I am, or use it as an excuse or a crutch throughout their life. And I think for me, in those situations in particular, helping parents understand it. So from my perspective, a diagnosis or a label is going to help provide understanding. And for a lot of teenagers or older kids, that diagnosis of autism helps them understand why they've struggled throughout their entire life. And it's almost relieving to them to understand that not everyone has some secret rule book that that they were given and that like teaches them how to be a person, that teaches them all of these different things. It's just their brain works differently and they have a harder time understanding these social cues. And so it's not something wrong with them. It's just a difference in their brain. And oftentimes too, I think the neurodiversity movement in particular, I think is really helpful in understanding that autism and ADHD are really just very much biological differences in the way that people's brains work. And they do come with difficulties, especially because our world was built for neurotypical people. However, they come with a number of different strengths as well. So a lot of people with ADHD a lot of people with ADHD are incredibly creative. And a lot of people with autism, they can turn these restricted interests into strengths, and into careers, right? I've worked with kids who have gone on to do coding and who have gone on to do animation and turned these things that they love into, robotics, right? Into careers. I think, a great example of this is Temple Grandin from the University of Wyoming. If you've never heard of Temple Grandin, I really highly recommend reading one of her books. But just her story in a nutshell, she's an individual with autism, and she is also a university professor at the University of Wyoming. She actually requires more support. She still, to this day, requires help with toileting, daily tasks of living, things like that. But she's a professor of agriculture, and she turned her restricted interest in agriculture and cattle into a career. And the entire United States and most of the world uses her humane slaughter of cattle method. And it's, I think, her autism, the way her brain works, helped her solve a problem that no one else could. And so I think in particular, just her understanding could just, so I think her perspective, she's also a really wonderful advocate. And she has this kind of slogan of the world takes all kinds of minds. And I joke about this with my parents all the time, but I'm like 10, 15 years from now when I see kids that are like designing the next rocket ship or the next power plant. I'm going to sit back and I'm just going to know that that their brain is the only brain that could have brought this to the world. So, all right, I think we're out of time.
Wonderful. Thank you so much, Olivia. I think Jeff said it best. We need 2 more hours with you. So that was wonderful. So thank you everybody for attending today's webinar. We hope you enjoyed today's content. We'd appreciate any feedback via the online survey. So see the link. It will be put in the chat. Certificates of attendance will be emailed to all participants who complete the survey, and they will be emailed at the end of this series. So once again, thank you so much for your participation. This wraps up NDCPD's Collaboration for Change webinar series for this year. We hope you enjoyed all the presentations over the last several weeks. We'll be looking through your comments and suggestions for new topics for next year's series. So stay in touch with NDCPD by liking us on Facebook or checking out our website. And I hope everybody has a great rest of your week. Thank you so much.
Thanks, Olivia. Well done.